Om Dham Dhanvantare Namaha. Ragadirogan, Satar Shaktan, Asheshakayan, Prasasheshan, Osukya Mohan, Adidan Jagana, Yopura Vajaya, Namos Tasmai. Let me share. The topic is study on Foley Catheterization. Foley Catheterization is done when there is retention of urine, maybe due to benign prostatic hyperplasia, urethral stricture, or the bladder neck obstruction due to tumor and other causes. It is done for therapeutic purpose also to inject the antiseptic substances to the bladder. This is the Foley catheterization. Urinary catheterization is a common clinical intervention to do adequate urinary drainage when patients cannot void effectively. When a urinary catheter cannot easily be placed, a thorough understanding of anatomic considerations that may impact catheter placement and fundamental working knowledge of various Foley catheterization techniques can aid physicians and other healthcare professionals in successfully enabling urinary bladder decompression. Placement of a Foley catheter is a common clinical intervention performed to allow for external urinary drainage. It is estimated that over 100 million urinary catheters are sold globally every year, with about 30 million used just in the United States. Urinary catheterization may be performed to relieve bladder neck obstruction, such as benign prostatic hyperplasia, strictures of the bladder neck or urethra, to treat acute urinary retention, or to adequately drain a hypotonic neurogenic bladder. Routine urinary draining is in preoperative periods or intensive care settings allows for improved bladder drainage, urine chemistry evaluation, and fluid monitoring. Urinary catheterization may be performed to obtain an uncontaminated specimen for culture, irrigate clots or blood from the bladder, instill therapeutic agents intravesically, and evaluate the bladder fluoroscopically or during urodynamic studies. While most patients tolerate urinary catheterization with minimal discomfort or complications, some patients will endure difficult, painful, or traumatic insertions. Such discomfort is often necessary, and multiple attempts at catheter insertion risk significant injury to the urethra, prostate, or bladder. Improper and suboptimal techniques for addressing difficult urinary catheterizations can lead to bladder distension, reflex, patient discomfort, mucosal damage, unnecessary therapeutic delays, serious urological complications, avoidable urinary infections, permanent scarring, and prolonged hospital stays. Now let us see the indications. First step in confronting a difficult Foley catheterization situation is to review the indications for the catheter. Urinary catheter may be placed to relieve acute or chronic urinary retention, obtain urine for analysis, dilate urethral strictures, splint the urethra, after surgery, perform continuous bladder infusions, manage hematuria, drain the bladder after injury, maintain the hygiene of the immobile patient, decompress the neurogenic bladder. Urinary decompression is also indicated in many critical care conditions to ensure adequate measurements of urinary output during prolonged surgeries for which the bladder needs to be empty. Foley catheters are possibly appropriate for measuring the urine only when fluid status or urinary output cannot be determined by other means. Just being in ICU does not automatically require the placement of a Foley. Patients who are able to void with acceptable post-void residual volumes and are not being treated for urinary tract with sepsis or infection probably do not need catheters. Now see the contraindication. A meticulous clinical history and physical examination for urethral trauma are necessary when evaluating a patient for urinary catheterization. Traumatic injury to the urethra is a contraindication to urinary catheterization without direct visualization. Clinical signs correlating with injuries such as blood in the urine, urethral meatus, and a high riding prostate suggest urethral injury and fit and attempt at Foley catheterization should only be made under direct visualization with the aid of a cystoscope. The lack of blood or high riding prostate is insufficient to rule out urethral injury. One must use clinical judgment when evaluating the patient's mechanism of injury to determine if a traumatic urethral injury is likely. If in doubt, a retrograde urethrogram should be performed. So this is a Foley catheter. The one end is having opening and bulb, other end is having two tubes, one to attach to the urinary bag, other to inject the water to the bulb. This is syringe and the Foley catheter. See, one side there is the opening of the bulb, another two tubes are the Foley catheter. So in situ, so the Foley catheter is done. One end is in the bladder, other is attached to a urinary bag containing this ICU. The bed is attached to the urinary bag is attached to the bed. Police catheterization is done and is attached to the urinary bag. So we see urinary bag that will relations measure quant of urine pass. These are the catheters. So in situ, the one end of police catheter is inside the bladder, and the bladder is the bulb is inflated. Another end is attached to the tube with the urinary bag. The urinary bag has the relation to measure the quantity of urine pass. Actually, first you open the catheter and apply the anesthetic gel to the surface of the tube, and the external urethral matter should be sterilized by sterilizing agent, and the catheter end is slowly pushed inside the urethra. When it reaches the bladder, the other end from the other end tube, we can pass the sterile water into the bulb so that it will fix it. Then the other tube is attached to the urinary bag. The Foley catheter. See, the males. The Foley catheter is attached to the bag, urinary bag. The Foley catheter is inside the bulb. The urine water is injected. The cystostome. When you cannot pass the Foley catheter into the bladder, you directly puncture the bladder wall and pass the catheter. This is a cystostome. This is the ICU pad with the catheterization. Patient is catheterized like catheterization is done. The male can see position of the catheter attached to the urinary bag. This is the catheter. In the one end, the bulb is inflated by injecting water, sterile water. In females, you see cystostomy, and we are not able to pass to the urethra. Cystostomy is the catheter is passed into the bladder. This is in situ the Foley catheter. So the substance was needed for catheterization. Foley catheter, cotton swab, sterile cloth, faucet, syringe. So in the container, urine is stored and sent to the laboratory for analysis. Catheter. So in the one end there is the opening in the bulb, in the other end there is two tubes, one tube for injecting water into the bulb, another tube to attach the tube to the tube of urinary bag. The urinary bag. You see, there are gradations to measure front of urine path. They are the so today we have discussed the Foley catheterization, its indications, contraindications. Thank you for patience.